Welcome to the Dermalorian webinar. This is another episode of our special series, the Itch and Rash Whisperer Virtual Grand Rounds, with Dr. Jenny Murase, who's the Associate Clinical Professor of Dermatology at University of California, San Francisco, and the Director of Medical Consultative Dermatology and Patch Testing at the Palo Alto Medical Foundation in Mountain View, California. And the nurse practitioner working along with Dr. Murase is April Martinez-Dulay from the Palo Alto Medical Foundation in Mountain View, California. We are so excited for them to bring their cases to us tonight to help us work through difficult cases and develop a type of algorithm or an approach so that when we walk in a room and we see something that's tough and we're kind of like, we have somewhere to start and we've got some knowledge to lean on. And they'll walk us through some cases today to help us understand how things work behind the scenes in their clinic. None of this would be possible without the recognition of the pharmaceutical industry and their appreciation of nurse practitioners and physician assistants in dermatology. So we want to thank our sponsors, AbbVie, Leo, Organon, and Sanofi Regeneron. So without any further delay, let's dive right into the tales of the itch and rash whisperer, untangling the mystery of your itchy, rashy patients. Dr. Murasi will turn the baton over to you. Thank you.
Thank you, Joe. This is the fourth and final webinar for this year, and it really has been a journey the past year in creating this really 4-hour online course to teach everyone about how to approach these really difficult to manage itch and rashy patients. And so this is going to be quite the tour de force today.
So this is what it looks like to be an itch and rash whisperer during holidays. As you can see, we're both wearing our holiday colors, and we're gonna have fun for today's webinar.
Yeah, we're going to have a lot of fun talking about itch and rash. And here are our disclosures. So if you have not watched the first 3 webinars, stop now, watch them, and come back to this moment because we are going to rely very heavily on the background material that we've developed in those first 3 webinars. So the first one, we really talked about the key elements of the physical exam and different forms of rash. So you could talk like a dermatologist. We went over key elements of history taking and also the basic immune mechanisms of rash. And we introduced 4 new handouts for you. We'll have a 5th one today. But those handouts included things like the soak and smear regimen, scabies therapy, intakes for difficult forms of rash and itch. And we also, in our third webinar, went over the therapeutics for atopic dermatitis, and we talked about the cytokine shift that can occur between Th1, Th2, and Th17. So we're going to take all of this information today, including our lymphocyte trumpet concept, and we're going to show how you can apply to combine your understanding of the diagnostic and therapeutics to care for these patients.
Yep, and today we're gonna talk about the application of diagnostics and therapeutics for all these hot topics. One of them is a bad eczema flare, which is what we call a topical steroid withdrawal. The itch with minimal skin findings, like very not much to see. The subacute prurigo, small itchy bumps, the id hypersensitivity, and also the neurotic excoriations.
So we'll go through these 5 really classic situations managing itch and rash.
So our very first case, our 32-year-old female, so she has this lifelong atopic dermatitis. She had this since she was infant. She had a history of a childhood asthma, so she's very atopic. In the past 4 years, she has this really bad dermatitis that is constant and unrelenting. She actually quit her job as a neonatal intensive care unit nurse, RN, prior because she has this really bad skin pain and her peak NRS scale on her face, neck, hands, arms, popliteal fossa, and her chest was 10 out of 10. So this is really severe that due to her pain, she spent most of her time in bed. So it's like bed bound throughout the day. She described her symptoms like itching, severe burning. It's like a zapping or shock-like sensation in the affected areas, even with and without movement. She had prior history of a methicillin-resistant Staphylococcus aureus. Was also on multiple antibiotics treatment. She plans to conceive, but currently she's not pregnant.
So, this is someone who really needs help, and she's describing the sensation of the skin sensitivity that really should cue you into the possibility that there could be some kind of topical steroid withdrawal or some issue with her skin as a result of that history that April just reviewed. And importantly, we had her fill out the fun intake at home before she came into the visit, and you can also have them fill it out in the waiting room. That's one of the handouts that you can get online through the DEF. And you can see that once you get this information to show the kinds of products that the patient is using, you see very quickly that she's not using just purely low allergy risk items on her skin. She is using Dove and Eucerin, but she's using some things with a lot of fragrance in them and also preservatives, surfactants that cause things to bubble up, and emulsifiers that provide the oil to water feel to products. And they can be higher risk products that patients are using. And unless we take the time to really ask them about what is being applied to the skin, we really are missing important information that we need to make sure that we're caring for them and getting them better.
So she's currently not on any topical medication. Patient feels that the steroids makes her worse, like a steroid topical withdrawal. And then also the non-steroid topical therapies causes burning when she applies it on her skin. She has used multiple topical steroids in the past and also non-steroid, including the pimecrolimus and tacrolimus ointment, was also on antihistamines, hydroxyzine at night and fexofenadine in the morning.
And she was strongly atopic, so she had had environmental testing and food testing previously at Kaiser. And she also had received the True test, which is a form of patch testing that captures about 30% of allergens, which means about 70% are missing, right? If we don't do the expanded series patch testing to get more information. But what we know so far is that she was allergic to two topical antibiotics, and she was not using the topical antibiotics at the time. Interestingly, she also had a very strongly positive anti-nuclear antibody in the past, as well as a positive anti-RNP. The pattern was homogeneous nucleolar pattern. It's not uncommon for patients with atopic dermatitis to have some polymorphous light eruption, which they can describe as a photosensitivity. Studies show that it's upwards of 30% of patients that can have that component of photosensitivity. So she had photosensitivity in her neck, face, and arms, but we don't know if this is some form of cutaneous lupus, for example. So a biopsy was done that showed eczema, spongiatic dermatitis, and not interface, and also a rheumatologic evaluation was done, and the rheumatologist did not feel that she had connective tissue disease, and they felt that lupus was unlikely.
So her past therapies include dupilumab for 8 months. She was also on 15 milligrams weekly dose of methotrexate for about 1.5 years. These therapies are strong, but initially it helped, but then stopped helping her. And so she also tried a narrowband UVB therapy for 5 months. However, due to her skin sensitivity, she was not able to tolerate the light therapy. Most recent bacterial culture shows staph infection and group B strep. She was on doxycycline for about 2 weeks. She also tried multiple rounds of oral prednisone and also intramuscular triamcinolone or volcanolog injection. The most recent therapy she's on is a JAK inhibitor, which is upadacitinib, 15 milligrams for about 6 months. She had an initial response, but then again, it stopped working, and so she stopped 2 months prior.
I think that the history with the narrowband UVB is particularly important because not only does she have photosensitivity, but just as a general rule, we say never put a hot atopic in the light box. And what that means, if the skin is very inflamed, the phototherapy usually is not a good treatment to start out with. So, in terms of thinking about her, in terms of her lymphocyte trumpet, she definitely has a significant amount of Th2 inflammation. We can see that with the strong atopic history, the history of asthma. The fact that she has this strongly positive ANA, brings into question, could there be a Th1 component that we would have to address? And then the potential for allergic contact dermatitis would be Th1, Th2, and Th17, really, because it's mixed. So there definitely is a component of this that we have to address in terms of anti-inflammatory in the immune system. She definitely has a skin barrier issue as well that we're going to have to address. And the nerve issue is both one of pain, significant pain, and significant itch. So we need to make sure that we're keeping track of these quadrants as we are going through and managing the condition. Now, in the second webinar, we discussed how the majority of atopic dermatitis patients, when they are coming in for flares, they'll describe that they've had this mild atopic dermatitis throughout their life. And then within the past few months or years, they're much worse than they've ever been, just like the patient we were describing here. And when we said that, we said there's two things you have to think about when you hear that. One is allergens, and one is bacteria, and doing that diagnostic testing to identify that. The other thing that we discussed was what you do when you're just developing a therapeutic regimen for the patient, because we have our emergency rescue phase that we're undergoing right now, where we're trying to get this very severe patient who's bedbound under control. But we also need to then move to a long-term maintenance phase. And when we do that, the rescue phase and the long-term phase has to have components of addressing the skin barrier, but also treating inflammation. So it's very important that we have all four of these components when we're designing the regimen. And so the nice thing about the soak and smear that we introduced in that second webinar is that it does affect all components. So we'll be using the desoxymetazone ointment and having her stop the different allergens and skin products that she's been applying to her skin to reduce her allergen exposure. Desoxymetazone is nice because it is a low allergy risk cortisone, and it doesn't have propylene glycol, which is very common allergen in topical steroids. And also, she's soaking in water and then using a cup of vinegar or a quarter cup of bleach in an adult-sized tub, and that's reducing the staph on the skin. But we're not just giving her Vaseline to treat the barrier or giving her prednisone to address the inflammation, but we're actually addressing both the barrier and the inflammation by widespread application. And so that's why this technique is so powerful and what we actually introduced to in her situation to get her better. So when we first approach a patient like this, we don't reach for therapy as the first thing. We need to make sure that first and foremost, we talk about everything that could be going on within the differential diagnosis. Then we discuss the diagnostic options, and then, and only then, we move to therapy. And that's how we get these patients better.
Yeah, so we talk about this differential diagnosis or what it could be. So like atopic dermatitis, eczema, secondary bacterial infection like staph and the strep. Also include allergic contact dermatitis as surfactants or preservatives that they use on personal products, cutaneous lupus, which is not immune, and also the seborrheic dermatitis, which is from Malassezia yeast. So these are very common in the eyebrow, sides of the nose, and scalp. We also talked about the diagnostic options. So one is the bacterial culture, given her history of staph infection, the patch testing, the extended series, given her she had limited number, like about 36 allergens from the true testing. So this is going to be an extensive one. The lupus panel blood test, also direct immunofluorescence biopsy, to rule out rare condition like a pemphigoid and dermatitis herpetiformis.
Yeah, and pemphigus too. So In her situation, because she had had so much steroid use, she actually did request a test to look for adrenal insufficiency. So we did an AM cortisol level. And another test that's important in a situation like this when they're getting recurrent infections, the antimicrobial peptides on the surface of our skin, they're dependent on vitamin D to fight infection. They're the swords that fight infection. So it's very common for patients to have vitamin D deficiency that you can identify in a patient getting recurrent skin infection. So what did we do for therapy now? So we did place her on soak and smear with topical steroids, okay, with desoxymetazone ointment and CeraVe, a cup of vinegar 3 times a week in a bath. We just asked her to take a leap of faith and try these steroids, even though she was concerned. We also did a decolonization regimen, and this will be the fifth handout that's available online for you. It's very helpful in patients that are getting recurrently infected. In a future case, we're going to show you as well that this is something that we used. So rifampin is a very effective antibiotic at decolonizing staph. It will turn your urine orange. So you have to inform the patients of that so they're not alarmed. And then we give doxycycline antibiotic, a Paradex mouthwash, which is chlorhexidine gluconate for the mouth to get rid of staph, mupirocin in the nose. If you put your fingers on your fingertip, sorry, the nose tip, the vestibule of the nose is right underneath that area. So that's where the patient needs to apply the mupirocin ointment. That is where the staph is living. And then also, they need to wash their sheets and towels every 3 days, clean the bathrooms and kitchen surfaces with bleach wipes, and that really gets the staph out of the environment. We switched her to Vetted for her face and then also Free and Clear shampoo. We recommended topical ruxolitinib cream for the face, and we had her stay off the JAK inhibitor for another month because she was already off for 2 months. Um, Three half-lives of a JAK inhibitor would be about 5 weeks. So you'd want at a minimum the patient to be off 5 weeks before they're patch tested if they're on a JAK inhibitor.
So we did an extended patch testing, and these are her results. Includes the fragrance mix positive, potassium dichromate, and cobalt. So she was really surprised that she was allergic to her own personal product, which is the Neogen cleanser that she's using and a Thayer's toner. So basically, she's putting a poison oak on her face every day throughout the years. And so we restarted her on Dupixent since the bacteria and allergens were identified through patch testing and bacterial culture. She had this like a minimal kind of itching 30 minutes after the injection, itching on her throat. But we recommended her to continue the therapy and take antihistamines like cetirizine and hydroxyzine, and she was able to tolerate the injections well. And so this patient remarkably improved with her dermatitis and her pain from the treatment. And so she has this, but she has this little bit of like an itching kind of persisted. So we added a nemolizumab for 4 months, and then she used the Dupixent alone for 7 months during her pregnancy.
So, in terms of women of childbearing age that have atopic dermatitis, I think it's important to understand how biologic medications work because this is an important part of her plan as well. So, when the antibody transfer occurs in the fetus, that occurs right before delivery. So the system is designed so that the baby gets an antibody boost from the mother right before they're introduced to the world and they need to be able to fight infection. So that's how the system's designed. So the syncytial trophoblast in the placenta will grab on to what's called the FC portion of the placenta of the antibody and pull it across the placenta. So that's why in cord blood levels and fetuses will have 1.5 times the maternal serum levels of these medications in the cord blood. And so it really is not a first trimester issue. There's very little transfer during that first trimester when the organs are forming during organogenesis and congenital malformations can occur. And this is really more of a third trimester issue right before delivery. So, to reassure patients worldwide, we developed a series multiple countries throughout the world. There were 85 total cases, and we looked at outcome measures for the pregnancies with dupilumab exposure, and they were better or the same in all categories for pregnancy outcomes. So this is very reassuring data. It's very likely to be similar for the other anti-13 agents as well over time. For the JAK inhibitors, there is an increased risk of spontaneous abortion with first trimester use. So it is important to treat your women of childbearing age on JAK inhibitors like you do your isotretinoin patients and order the pregnancy test. Make sure that they're aware that they need to be on two forms of contraception because initially when medicines come out, they can have an increased risk of spontaneous abortion and the specific malformations that can occur are really delineated over time when there's enough data to support that. So for the time being, it's really not something that we recommend, for pregnant women. And I think that one of the most important parts of this case, particularly, is that this is a patient who said that she has topical steroid withdrawal and failed dupilumab, who was treated with topical steroids and dupilumab successfully. So it wasn't the fact that the therapy that was chosen was wrong or failing the patient. It was that the diagnostics had not been performed. And that's what took her from being someone who is bedbound to someone who can function, live their life normally, and then also have the child that she always wanted and become pregnant. So really, when you hear a patient telling you, oh, I have topical steroid withdrawal, I want you to think, I need to do diagnostics because if you have a rash and you put a topical steroid and you locally immunosuppress the area, the bacteria then, because of the local immunosuppression, will start to grow out of control and it'll get better, but then it'll get much, much worse. Or if you have the topical steroid and you put the topical steroid on, it's an anti-inflammatory, so it might initially get a little bit better, but then you get the allergic reaction to this topical steroid or to the propylene glycol, and then the skin gets much, much worse. So these two things, these allergen bacteria, they present as topical steroid withdrawal. So it's really a sign to you that you need to do the diagnostics and really not blame the therapies for failing the patient when the diagnostics haven't been done appropriately.
So our case number two is our 38-year-old male. So he's very, very itchy. He has this minimal skin finding, so nothing much to see. It's affected on his trunk, arms, and legs, and he has been suffering for more than 10 years. And 80% of the itching happens at night, and he described it as a deep and burning. So he's very dermatographic. So when we say dermatographic, it's something that we mark X spot on the skin, and then the skin welts up. So what it means is that this patient has a load of mast cells that is degranulating. And this dermatographia started about after COVID in 2022. He has this very occasional, like follicular eczema, really nothing much to see. So, what are the diagnostic and therapeutic considerations?
So we refer to these kinds of patients as having invisible inflammatory dermatitis. And what that means is that even though there isn't that much to see on the skin, it's likely an underlying inflammatory process that is driving the itch. So what could it be? So if it is mast cell driven, like in our dermatographic patients or our patients with chronic spontaneous urticaria, we really unfortunately have pretty limited testing that we can do to identify potential causes. You could consider doing a CBC to look for eosinophilia because parasitic infection will have high eosinophils. You might want to ask for if they have high eosinophils about a history of traveler's diarrhea. So there's two stool tests and one blood test that you can do. You would do a stool test for ova and parasites that is for ascariasis, or because the Giardia infection occurs higher up in the gastrointestinal tract before it gets down to the stool. Usually the ova and parasites are destroyed, so you can do an EIA to really look for the Giardia through an assay, and you can also do a blood serology for strongyloides because those would be the top three. Or you could do a sedimentation rate to look for generalized inflammation. If you're considering using something like Xolair, omalizumab, you could do an IgE level to see if that's elevated. Um, SPEP would be something that you would consider if they were having both bone and joint pain, because there is an IgM gammopathy that is associated with hives, bone, and joint pain. That's called Schnitzler's syndrome. And finally, there's a test called an FCER1 assay you can order. It, depending on the lab, it's also referred to as a histamine release assay, and it can also be referred to as a CU index or chronic urticaria index. Now, sometimes insurance will not pay for this test, but patients will kind of want it anyway sometimes because they want to know, do I have an autoimmune predisposition for developing hives? It won't necessarily affect the therapy you choose, but it's informational for the patient. So sometimes they like to know if they have an autoimmune predisposition.
Yeah, and we also have to consider the drug dermatitis or oral medications that they're taking, especially for those who are taking antihypertensive medication like calcium channel blockers, like amlodipine, like rotating their medicine. Also, the dermatitis herpetiformis or celiac panel blood test to rule out gluten sensitivities. Also, we can consider doing biopsy for bullous pemphigoid, doing ELISIS test, BP 180 or 230, biopsy for mycosis fungoides, or blood test for leukemia and lymphoma panel.
And allergic contact dermatitis has also been reported in situations like this where it can be more subtle, especially in our skin of color patients. The erythema can be quite subtle because you can have allergic contact dermatitis to clothing. Melamine and urea formaldehyde are in fabrics that are labeled permanent press or wrinkle resistant. And also, you can be allergic to the dyes in the clothing themselves. So that can be detected with the textile series or patch testing. And so, on occasion, we've had patients just wear tan clothing or white clothing, really try to minimize a potential for clothing allergic contact dermatitis. And finally, notalgia paresthetica and acquired cutaneous brachioradial pruritus are conditions where there's actually nerve compression that's causing the itching. So if there's compression, let's say from a whiplash injury, in the C-spine from 5 to 8, that presents as itching on the forearms. Um, if they have little osteophytes forming in the thoracic spine, which tends to occur over time, right? It's very common to have notalgia paresthetica. That's a compression in that T2 to 6 area of the spine. And of course, these conditions particularly are not actually inflammatory disease that's driving the itch. It's actually due to the nerves themselves.
So this patient had tried topical steroids and non-steroid, including the pimecrolimus cream. Also, he was treated with permethrin to treat scabies. Um, Oral and injectable medications, antihistamines, famotidine, H2 antihistamine, also a mast cell stabilizer, which is the montelukast. He was also on a strong oral medication for itch, which is the gabapentin and pregabalin. He was on prednisone, tapering dose, intramuscular triamcinolone injection. He was also on omalizumab for about 7 months without a resolution, and also he tried dupilumab for 3 months without any improvement.
So in a patient like this where they have a little dermatographia but not much, the initial conversation that we have usually focuses on the mast cells. So we'll describe the mast cells as these essentially like a firecracker under the microscope. So they're covered in these packets of histamine and they explode and degranulate and they release histamine and then the membrane gets very twitchy and it stays twitchy for about 3 months. So when we're placing patients on therapy, we'll oftentimes start, let's say fexofenadine doesn't cross the blood-brain barrier, so we would start, a pill of that, let's say in the morning, and then we might add famotidine, which is going to be under the antacid section of the over-the-counter medicine as an H2 blocker. That's also not going to cross the blood-brain barrier. Cetirizine can make about 10% of patients sleepy, and certainly diphenhydramine makes patients sleepy. So we'll kind of layer these antihistamines every few days or every week and get them to a dose that's controlling the mast cell degranulation so that they're not getting itchy. And so the danger is if they stay on for a few weeks and they just go off, and then the mast cells degranulate again, boom, you have another explosion of the firecracker, and the mast cell membrane is very, very unstable again. So it's kind of like Pandora's box. You don't want to keep opening Pandora's box and boom, it explodes, and then you do it again and boom, it explodes. You want to keep the box shut. You keep the box shut by having these antihistamines on board. You give it 3 months and then slowly taper off. And that would be a common way to treat a patient like this. But this patient is having minimal response to systemic steroids, is not responding to Th2 blockade. So, something else is going on. So what would be the next kind of thing that we would think about?
So we consider a JAK inhibitor, which is upadacitinib, 15 milligrams daily. Given that the severity of his pruritus, we also consider doing labs for like TB screen, hepatitis B and C titers, and his TB screen shows indeterminate.
So this was before we had access to nemolizumab medicine, and we were doing this TB screen to prepare him for the JAK. And when we did that, okay, we do a chest X-ray. Well, he had a mass-like structure in the anterior superior mediastinum, and so he actually was ultimately diagnosed with Hodgkin's lymphoma, and that's what was driving his itch. So the important point to remember, I think, as all these new therapeutics are coming out, these are all the therapeutics that have even 48-hour anti-itch data. And this table is not meant to compare the therapeutics, it's just because they're very different studies, but just reporting the fact that all these therapeutics do have improvement of itch within a 48-hour interval. And nemolizumab in particular, there was a 67% improvement. There was an average of a 5-point reduction in the NRS score. And you can see here the patients that were experiencing burning, the 10 patients are on the left, and itching with the 60 patients on the right. You can see that dramatic decrease in the itch in that first week. And this study did include patients with leukemia and lymphoma. So this really speaks to the fact that as we're using these new powerful therapeutics to control itch, we need to really make sure that we are being careful, and the onus is on us to do the right diagnostic testing to make sure that the patients are being treated. And I think that's why this table is so helpful as a guide.
Yeah, exactly. So we have to make sure to consider underlying metabolic condition before we even start patient on the strong therapies. So these are the conditions, but are not limited to the immunodeficiency and leukemia, like hepatic diseases, parathyroid disease, diabetes, malignancy, infectious diseases that are associated with pruritus, and also blood dyscrasia and the dermatitis herpetiformis or celiac diseases.
So you can consider these tests when you have a patient that really isn't responding. They're a bit dermatographic, have urticaria, but they're not responding to therapy as you would expect. You can consider making sure that you're not missing anything important. And this case really speaks to the fact that because he had the underlying lymphoma, he did have lymphocytes. He had a lymphocyte trumpet that probably involved all three aspects, 1, 2, and 17. And so it was the immune system that was driving the itch in the nerves. There's very little to see on the skin, but it was identifying the change in the immune system that resulted in the improvement of his pruritus.
And our third case is our 75-year-old man. So this patient has a history of a non-melanoma skin cancers, and he also had this irritated seborrheic keratosis, the benign growth on his trunk. He presented in clinic with this months of a very pruritic eruption on his chest and his back, and he was clinically diagnosed of what we call the Grover's disease.
So subacute prurigo or these little itchy bumps or Grovers where they get the itchy bumps on the chest and abdomen. It's pretty common condition that we see
Yep.
and in older patients. And it really is a sign that the Th2 arm of the immune system is elevated. That's what you should think when you see Grovers. When you biopsy, it actually has a cool look under the microscope. So it looks like what we call a dilapidated brick wall. We refer to that as acantholysis. So it has a unique look. It's not just a
Mhm.
spongiotic dermatitis like an eczema. So when you get that biopsy back, it's a sign that Th2 is strong. And this is a really good patient to make sure that does not have scabies. You need to lift up that foot and you look really carefully on both sides of the foot. You look, this is an ankle area, the inner ankle. If you look carefully, can you see the little burrow, the thin line, right? It's right there. So if you take your 15 blade and you go right over it, it's going to look like you took a red ink pen and you made a little line. That's what the scabies burrow looks like. That's what you have to look like for on the ankles. Also looking for the finger webs to be able to scrape. Um, the penis in men, if a man is itchy and getting a lot of bumps on the penis, that's a sign that it really could be scabies. Areola in women is a very good place to get a positive scraping, and of course the ankles and the bottoms of the feet and the sides of the feet.
Yep, and we also consider doing a blood test for CBC, a complete blood count with differential to rule out leukemia and also parasitic infections. Doing a skin biopsy, like a direct immunofluorescence, to rule out our autoimmune disorder like bullous pemphigoid. Also, there's a blood test for that, the BP 180 or 230 ELISIS antibodies for bullous pemphigoid, as well as our celiac panel blood test to rule out dermatitis herpetiformis.
And the key elements of the history taking for a patient like this. So, is this the worst itching you've ever had in your entire life? That's how scabies presents, the worst itch ever in the entire life. Or if other family members, particularly someone that they're sleeping next to, is starting to itch, that's also a tip off. If they've been in the hospital recently, or if they've been in a skilled nursing facility, that's another tip off. So, scabies is the only mite that lives on human skin, which is why it can be treated and cured with ivermectin and permethrin, as in the scabies handout that we provided online through the DEF. Now, there are other mites that will bite the skin and fall off. So that most commonly would be a rat mite or a bird mite. And you have for the rat mite, you can ask about crawl spaces or attics. Have they heard any scurrying? Maybe having pest control come by if they're getting this subacute prurigo padding, these itchy bumps. Do they have ivy around the house because rats can be in the ivy? Do they have bird feeders or birds? Also, if they have a lot of oak around their house, there's an oak gall mite that can cause a similar pattern. And so you really want to have them thoroughly clean all of their carpets to try to get rid of these mites. As April mentioned earlier, for elderly patients, we definitely want to ask about new medications, especially we want to screen for calcium channel blockers. I will have them stop any new medications, but even if they've been on amlodipine for a really long time, I will have them stop amlodipine because I've seen so much itching in older patients, specifically from the calcium channel blockers. The photo that's provided on the slide is what oak gall looks like, so that you can explain it to your patients. And so Grover's, which is referred to as transient acantholytic dermatosis, is really quite common. It's seen in elderly patients with more men than women in a 10-to-1 ratio. And because it's seen in these Th2 dominant states, we think about it in HIV disease, in scabies, and bullous pemphigoid. When we spoke in the third webinar, we talked about using the Th17 suppressive agents like the IL-17 and IL-23 blockers. When you do that, you increase Th2. So you can definitely see it in that situation as well. But what's interesting is that as we get older, our immune system reduces our cell-mediated immunity over time, that Th1, and that results in itchy red bumps in patients, which we refer to as immunologic eruptions of aging because of the immunosenescence. That's why during COVID, it was easier in your 60s and older to develop the infection, the COVID infection, because the cell-mediated immunity is going down. So when you see new onset Grovers, you want to ask your patient, have you had the shingles vaccine recently? Because if their cell-mediated immunity is going down, that means they might not be able to contain the virus in their dorsal root ganglion and they can break out in a shingles infection.
So what we did for this case, we did this scraping for scabies and it was negative. We actually done three biopsies. Two came back as spongiodic dermatitis or eczema, and one is Grover's. The direct immunofluorescence and ELISAs, as well as the celiac panel tests were negative. We have him off with his oral medication, like a rotation, at least minimum of 3 months, and initially put him on a soak and smear. That was a rescue in long term, that Dr. Murase discussed earlier.
And then I think it's important to mention permethrin use in this situation
Mhm.
too. So, permethrin will actually treat and cure scabies. But because it acts as like an insect repellent for mites for a week after application, it can also be a clue for rat and bird mites. So if they do 3 applications a week apart and they're better, and then the bumps start going back, it's a hint that they really do need to get pest control to come into the house. This patient was actually treated initially with narrowband UVB phototherapy, but ultimately was switched to dupilumab and cleared. There are data to support the use of both dupilumab and nemolizumab for treating Grover's, but I would imagine that any IL-13 agent, such as tralokinumab or lebrikizumab, would also work in the situation because they're all suppressing Th2. In terms of oral antipruritic therapy, we'd already discussed the antihistamines. Neurontin and gabapentin, there's a huge range that you can use when you're dosing those medications. So I usually start off at about 300 and I'll increase every few days. It ranges from 100 to 3,600 milligrams. So it's a huge range in dose. And we certainly have had patients up that high
Yeah.
because they needed it to control their itch. I actually like Lyrica or pregabalin more than gabapentin. And that ranges from about 25 to 400. I usually start at about 50 or 75. Doxepin is a medicine that will definitely make patients very, very sleepy. And you can have a little, 80-pound woman who is taking 100 milligrams a day and not sleepy at all. But then you can have a 300-pound man taking 5 milligrams of doxepin and just be knocked out. So it's very patient dependent, not necessarily dependent on weight and size. So you want to start low and increase. If you're prescribing over 50 milligrams a day, you do want to make sure that EKG is ordered to look at that QT interval to make sure they don't have long QT. Amitriptyline will also make patients sleepy, and that there's a range of dose for that medicine as a tricyclic. I like mirtazapine or Remeron for elderly patients because they tend to tolerate it better in terms of side effects, and naltrexone, which works very well, especially for hepatic itch. But the bottom line is all these itch therapies that are oral therapies, they can result in fatigue, they can have somnolence, sleepiness, their mentation changes. And so it can be very difficult for our patients that are older to be experiencing these changes in mentation, which is why the biologic agents that are out for itch are so helpful to patients because they don't have those side effects.
Speaking of elderly, our case number four is not so old patient. We have our 91-year-old female with new onset of the severe pruritus. It was so severe that it's affecting her sleep. She came in clinic with her daughter, and she was saying that she would go in showers in the middle of the night just to get the temporary relief of that itch. Her peak NRS scale or numeric rating scale is 10 out of 10. She was hospitalized 6 weeks prior. She didn't have any history of atopic dermatitis or childhood asthma or pruritus when she was younger. She's currently on multiple medications, including the congestive heart failure medication, fibrillation, coronary artery disease. She has type 2 diabetes, and hypertension, and also had history of a vulvar cancer.
So here is what she looked like, and you can see those linear excoriations. So your eye goes to sort of that scratched look. And it's really important in this situation when you see these bright red lesions on the legs, you see that there's central crusting to those. Okay, so she's scratching the skin and injuring the skin, and the body's creating inflammation to heal that wound. That is different then extravasated red blood cells in this picture that we showed you in the first webinar of a leukocytoclastic vasculitis, where there isn't the crusting. So you have to be able to clinically distinguish. Now, if you biopsied the lower leg, to rule out a vasculitis, I certainly wouldn't fault you for that, even though biopsies below the knee do take longer to heal. But it's important to notice that clinical difference. And if you continue to look, and we looked all over, you can see that what we're seeing is secondary change. We're seeing these scratch marks on her, itchy bumps that she's scratched, but there isn't a primary lesion. There's no eczematous plaque. There isn't the vesicle for us to do the diagnostics on. It really is mostly secondary change, and you can see some inflamed seborrheic keratoses that if you pull down the diaper a bit, you can see. And so when we think about this patient, so she's older, so definitely Th2 inflammation is something that it would be, I think, worth considering suppressing, right? She definitely has a very strong itch nerve component. We think it's Th2 inflammation. The skin is less involved, right? And at this point, we really don't know if there are the Th1 or Th17 side would need to be suppressed as well. So what do we do for her?
So we did a scabies prep. So we did a prepping and it came back as negative. So she was negative for scabies. We put her on hydroxyzine, 10 to 50 milligrams at night. Tapering dose of prednisone. We started with 60 milligrams for 3 days, down to 40 in 3 days, 20 milligrams for 3 days. We initially placed her on soak and smear regimen using the Sarna lotion for sensitive skin, mixed with the steroid fluocinolone. And then 2 weeks later, she still have itching. She still have the 10 out of 10 NRS scale, and the steroid didn't do much for her.
So we look on exam and she still is scratching herself, but there's a little bit of eczema at the top of her bottom, right? And we look closer and we have actually a really nice plaque that we could biopsy to do some diagnostic testing this time. Now, when the skin atrophies for mycosis fungoides and it gets that cigarette paper wrinkling, it's harder to appreciate in an older patient that has atrophy because of their aged skin. So we're going to biopsy, and we're going to biopsy in this situation for both mycosis fungoides, and we'll also get information about it could be bullous pemphigoid. We're going to be doing a DIF right next to it for bullous pemphigoid, and then also an ELISA for bullous pemphigoid to make sure we're not missing that diagnosis, because 20% of the time it can be non-bullous state, and you don't want to miss it.
Yep.
And then we're doing a CBC for leukemia. But the case becomes more and more interesting because in spite of using nemolizumab, which is really effective, if there's not much to see on the skin and a lot of itch, it's really effective. But it's not, she didn't respond to it. And she's not responding to dupilumab as a Th2 suppression. So, and it's really only mildly responsive to oral steroids. So, what is going on in this patient?
So this patient, as Dr. Murase mentioned, despite of like taking all the strong therapies, she came back and still have this persistent pruritus. And so this is affecting her genitals. It's so easy to miss about the genital dermatitis. This patient mentioned that she's been applying Vagisil multiple times throughout the day since she was diagnosed with her vulvar cancer, and she was never really truly cleared since that time.
And so we look, and there's this rip-roaring red dermatitis covering the labia in the inguinal creases. You can even see some satellite papules around the anal area where we start to think about Canada. So even though we did a really thorough exam, we showed you that physical exam initially, unless you actually have the patient's diaper removed, you really don't know what's going on in the genital area. And you can see here the KOH that we did was positive for the pseudohyphae of Canada. And in addition to that, it has the look of an allergic contact dermatitis. She's been putting Vagisil, which is very high risk with the allergens present. She's been using a ton of it for a long period of time, and it's smeared in this area and likely driving a lot of her um, inflammation. And so, what does an id hypersensitivity reaction mean? What does that mean when we use that in dermatology? So, in the third webinar, we explained how rashes exist not in the skin, but in the immune system. So, if you have a patient that has a localized, really, really bad dermatitis, let's say that they have stasis dermatitis on their lower leg, really, really severe. What can happen is over time, because these immune cells are circulating, they can get a little bit on their arm and then they get a little bit on their trunk. And it can kind of spread to other areas of the body. And we refer to that as conditioned hyperirritability. We also refer to it as an id reaction. And when it gets completely uncontrolled, it can evolve then into a state of autoexemdatization where the patient is just reacting everywhere and the skin is very, very sensitive. And they can go in and out of these phases. So the question for this patient is, does she have a localized severe allergic contact dermatitis? And we talked about how there's 1 and 2 and 17 components to that. And that's what's potentially driving, in addition to the secondary infection with the Candida.
So for this patient, she had biopsy a year prior on her right vulva, and it came back as a squamous cell skin cancer. So she was treated with Aldera. So what we did is we did biopsy again. So we rebiopsied her, and it came back as spongiotic dermatitis, which is eczema. So there was no evidence of squamous cell skin cancer. So what we recommended is to stop her Vagisil, and because of the KOH was positive for hyphae for yeast, we started her on iconazole cream and also oral fluconazole 200 daily for 2 weeks with a course of a prednisone.
And she comes back and she's scratching less than she was, but she still reports an NRS of 7 to 8. So the vaginal area is much better. And at this point, the daughter has obtained the list of medications that the pharmacy has dispensed in the past 6 months, which is what I usually ask. I ask for the sheet that the pharmacy can easily print out that shows the actual medicines that the patient was getting. And when I look at that list, I find that the Jardiance was started 6 weeks prior to the development of her itch. This is a medicine that increases glucose excretion in the urine, so it's associated both with diffuse pruritus and allergic reactions that have been reported, but also an increase in genital yeast infections, which she did develop as well. So then we trial her off the medication, and we also consider doing patch testing in her to the Vagisil and other products given what happened. So I think that that case was particularly helpful because it really did ask us to focus on making sure that our physical exam was very, very complete and thorough. And it also is an important reminder to still keep those medications in the back of our mind and really get that information from the pharmacy so we can make the correct diagnosis and really to keep our differential broad because we are the kings and queens of the multifactorial diagnosis in dermatology as providers.
Right. So for our final case, our number 5 case is our 67-year-old female. I remember her in in my head, like really, it was just very, very intense itch. She described it as electric sensation. And this patient has been suffering for over 10 years. So she didn't have any history of anxiety or depression. She's not taking any oral medication at this time. She said that life is low stress level and vehemently denies, scratching or picking or cleaning at the areas on her skin. Her desmoglein 1 and 3 antibodies and the celiac panel tests were all negative. We actually did a biopsy on her right chest at that time and came back as urticarial hypersensitivity reaction and also epidermal ulceration with mixed inflammation, basically saying that inflammation from scratching.
And so the desmoglein 1 and 3, what that's doing is that there are a lot of erosions. Both pemphigus vulgaris and pemphigus foliaceus can present as erosions all over the body. So the referring dermatologist had done due diligence and done that testing as well. But what the biopsy is really telling us is that the patient is manipulating her skin. And you can see that in the way that these linear erosions are present. We talked about those in the first webinar where they're scratching the skin and you can see those hypopigmented marks. That's really a sign that the patient is the one doing this and is manipulating their skin. And remember, she vehemently denied that she was doing that, but you can tell
Yeah.
just in the physical exam, it's present where she's able to reach. And so, what we do when we think about patients like this is, um, the question is, of course, is this all secondary change? Is there anything going on with the immune system that will require us to balance the Th1, Th2, and Th17 cytokines? Is this something that there are actually primary lesions in the skin, or is it all nerve pain? And the main thing to ask in this situation is why? Why is the patient picking the skin? That you, in order to change the behavior, you have to understand the why. And it can be really hard for them to describe how they're manipulating the skin. She denied, and then, you ask more, oh, well, there's these red spots that are stringy, and I'm pulling them off in the shower as I'm rubbing their skin. They're coming off. And then she starts to confide more and more over time. So the where, the when, and the how are very, very important. Are they using tools to pick at their
Hmm.
skin? Are they doing it while they are studying at night for their homework that they find themselves scratching? Is it in the bed at night that they're noticing the crusts and they're kind of getting them off the skin that they could wear something long like pajamas? Are they doing it in front of the mirror where they're looking really, really closely at their face that they can cover the mirror with wrapping paper and not get so close to it to try to prevent that behavior? And importantly, what feeling do they have on their skin? This cutaneous anesthesia that they experience.
Right. And also to understand why, we also consider doing biopsies for primary lesions. Like, for example, if they have this vesicles or plaques, we can consider biopsy. Also doing bacterial culture with the erosions or pustules. She actually was positive for STAP. And so we did place her on mipiricin ointment and oral antibiotics and did the decolonization that's discussed by Dr. Murase earlier. And it's really important also to focus on understanding the symptoms of the cutaneous anesthesia in this condition.
So we treated her MRSA and decolonized her, and we asked very carefully about what she was experiencing. Now, in this situation, she was not under a lot of stress, but it is very, very important to understand the life stressors of your patients because when we scratch at our skin, actually, when we feel our skin even lightly, there's a pleasant sensation. It releases dopamine in the brain. So you'll see monkeys in the zoo and they're going through each other's hair, right? Because they're trying to remove infestation. So we naturally have the pleasure center of our brain activated by scratching at the skin. So the layman's term for prurigo nodule is a worry wart. If we're worried, we're going to scratch, and that is a way that we self-medicate. So patients do that, and we refer to this as BFRBs or body focused repetitive behaviors. And there are website resources. This is from an article online, and I always use this table from the article. I just copy and paste it into my after visit summary, where patients can actually use these internet-based self-help interventions and they can prevent their BFRB. And this is particularly helpful if the patient is not experiencing the cutaneous anesthesia that April was just talking about, like a feeling on the skin that's going to drive it, and it's actually the behavior itself, right?
So we also consider using the hydrocolloid dressing. So these are providing the moist healing environment to our skin. It forms a gel and absorbs the wound exudates. For this case, for this patient, we use the Vashi wound solution, Promogran and Prisma collagen matrix, and we use this duoderm to cover it and making sure like using as the barrier so patient doesn't touch or peel the skin.
It's really important to say you can absolutely not touch it. You remove it and then you immediately put something on. Do not touch. Let the skin heal itself. Now, patients that have neurotic excoriations, like the patient that we just described, are on a spectrum with patients that actually have delusional infestations. So the truly delusional patients, that's a fixed false belief. So they will always believe that there's a parasite or infestation that's driving it. Um, And you will always believe that there is not a parasite, right? So you have to focus on the area that you can come in agreement with, which is improving the patient's quality of life and therapy when you can't agree on the etiology, what's causing the problem, right? Now, in a patient like this, she's experiencing formication, which is a sense of something crawling on her skin that she starts to tell us about, that's why she's scratching. Now, she has insight to know that it's really not a parasite there, which is very helpful. But what's interesting is that patients with this formication, even if they're not delusional, can actually respond to pimozide. So what we did for her when she started to describe this formication feeling is that we did a trapezoid dosing. So we started off at 1 milligram, and then after 3 to 4 weeks went to 2 milligrams. After 3 to 4 weeks went to 3 to 4 weeks, and then 4. Have her stable for a few months, then we taper down. And we do an EKG before that also to look for that long QT interval before starting the treatment. Now, the other thing that's important is the sensation that the patient's experiencing can actually evolve over time. So, for first, she was describing more formication, then over time, it became a deep itch, in which case, nemolizumab was what ended up curing her. So she started off needing the pimozide, and actually a loading dose of nemolizumab did not work, but over time it was the nemolizumab that helped her. So you really have to ask why they're scratching because it does change over time, and the feeling they're experiencing is very, very important to getting them better.
So as you can see in these photos, I actually follow through her case. I see her every single week. There's only like a few papules on her trunk and her extremities. Um, Also, her back and her neck is clearing.
And so the staff become even more important because these patients do require a lot of frequent visits. They want to be taken seriously because they don't know what's going on. So, doing the thorough exam, doing the cultures can all really help to facilitate that rapport and getting the patient better. You want to focus on the points that you'll be able to come develop a common understanding about. So, you know, um, I realize that you can't continue to live this way. We really need to focus on therapy. I've seen other patients improve through empiric trials. When we don't really know what's causing it, we still focus on trying to improve the skin barrier and use these neuropathic agents to improve the sensation you're experiencing and focusing on the things you can be in agreement about. Because these patients really speak to our calling as providers, just like the patients with itch and rash speak to our calling. There's an expression, guérir quelquefois, soulager souvent, consoler toujours, which means to cure sometimes, to relieve often, but to comfort and console always. And that's really, I think, our role ultimately as dermatology providers caring for these really itchy, rashy patients. So, thank you so much for joining us on this journey this year in the spring, summer, and fall, and now the winter. And we really hope that this 4 hour course helps provide a foundation for you to care for these patients that are really suffering and need you.
Exactly, and I agree. And thank you for having us. And remember to use your tools, your fun intake, your diagnostic tools, your therapeutic options, and have fun while caring for your itchy, rashy patients.
Dr. Marazzi and Jenny and April, thank you so much. And I think that we should also mention that not only did our clinical acumen and skills become greater because of your thoughtful contributions in this series, but also this series also resulted in April's new baby. So, April, congratulations again.
Thank you.
Thank you for hanging in there with us through your pregnancy and your new birth, and it's so wonderful. Dr. Marassi, thank you for sharing your skills and incredible experience dealing with these difficult patients that we all strive to take great care of. So, with that, we've come to the end. A tremendous thank you to both of you for your contributions, and we look forward to doing more with you in the future. The Dermatology Education Foundation, again, wants to extend our thanks to our industry partners, AbbVie, Leo, Organon, and Sanofi Regeneron. Without their support, these types of educational events would not be possible. So, as the reps come through your office, thank them and thank the companies specifically for supporting the Dermatology Education Foundation so that we can continue to bring you these sort of events with their support. So with that, we want to say good night to everyone and thank you for your participation.